Hi, I am Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Hi, everybody. Welcome back. Okay, I have to tell you about my weekend.
Oh, tell me.
Okay, I thought I was a dog person.
Oh,
I'm a cat mom now.
You're a crazy
Actually,
cat lady.
I'm a dog and a cat mom because I had 2 dogs.
Mm.
And then now I added 3 kittens to
Oh
my family.
Gosh, disaster.
Okay, and this is a pretty crazy thing to do, but here's the thing. These little kittens were abandoned by their mom,
Oh.
okay? There were 4 of them, and one person took one, and I was going to take one, and somehow I ended up with 3. But they're so cute, and they're so sweet, and I didn't realize, because I haven't had a cat, probably since just a long time ago.
Yeah.
When I was a teenager or something, but these little kittens, they think I'm their mom now.
Oh.
And it's so sweet. I love them. Every time they see me, they come meow. So I am a crazy cat lady now. So just so you know, but if you would like a kitten, I do have extra. So
no, Stephen would kill me if I brought up a kitten.
Yes. And okay, I love reality TV. One of the shows we talk about a lot is Vanderpump Rules, actually. And one of the people in that show, her name's Sheena Shea.
Mm-hmm.
What's so crazy is I got my 3 kittens. The next day, Sheena Shea got 3 kittens.
She copied you.
She copied me. Exactly.
Oh my
Rude.
Influencer.
Yes. Yeah. Okay. So I know you're not on social media that much, but there have been some social media fights going down between fertility doctors. And of course, that always catches my attention. So I wanted to kind of get your thoughts on this topic that's coming up. And so I'm not going to name the fertility doctor names because I don't want to call anybody out. But one fertility doctor kind of came out and made this very absolute statement that said, when you're doing an embryo transfer, you have to be doing a natural cycle transfer. And if you're not, you're doing it wrong, basically, right? That's a very absolute statement. And of course, that is really stressful for patients to hear something like that, because if you did not do that type of cycle, you're thinking, oh my gosh, why didn't I do this type of cycle? And all the rest of it, right? So it's really stressful to make such absolute statements like that. And so other fertility doctors then kind of did a response to that, where they said, look, you're really just trying to make a very complex topic into a soundbite. And there's lots of different recipes and lots of different reasons why we may recommend or offer certain options to certain people. And so I thought it would be good for us to really kind of break down the complexities, because here's the thing. If you're going through Instagram or TikTok, this is a 15-second, soundbite. Yeah. But we've got a whole podcast. So let's get into the nitty-gritty. Let's get into the details. But first, I was going to see, can you explain to the audience, why is this even an issue, right? We've been doing IVF for a long time, but I don't know if people really realize we've changed how we've done IVF, right?
Yeah, absolutely. Yeah. I think just the whole process and how we go about it, I think we've gotten a lot better at it and timing it, and we've gotten more creative with our cycles in general. But when you think about a traditional embryo transfer cycle, the most common way that we used to go about it is a programmed cycle. And programmed cycles basically mean we take control of your cycle and we mimic your natural hormonal cycle for a transfer. We give you estrogen first, and then we give you progesterone. And so we kind of hijack everything. Everything's very controlled. Our levels are very specific. It's very well studied. We know where those levels should be. So I think there's actually a lot of support out there for a program cycle. That's the most common way anyone's going to do an embryo transfer, at least in the US. And then, more recently, I would say it's gotten really popular in the last 5 years, but definitely has, been around for longer than that. There's now a newer way to go about embryo transfers called natural cycle transfers. And even amongst that, there's kind of subgroups of natural cycle transfers. The most natural transfer you could possibly do is where we just kind of let your body do its thing, right? You're going to grow a follicle. That follicle is going to release the estrogen, and it's going to be the estrogen that makes your lining grow. It will ovulate and it will shift to a progesterone environment. And that's what we use for the progesterone. I don't actually know of anyone that does like a true natural cycle. Most of us are doing a modified natural cycle where we actually control the time that you will trigger and actually ovulate. So we know exactly when that's going to happen with a lot of precision. But these are newer takes on how we can do that. And I think there's pros and cons to both.
Yeah,
for sure.
Absolutely. Well, one thing that I think is really interesting too is we say it's new, but it's kind of old if you think about it, right?
Yeah.
Because, okay, way back when with IVF, the way you would do it is you would take your fertility injections to help your follicles to grow. You would do your egg retrieval, and then 3 or 5 days later, they would do your embryo transfer. We call this a fresh embryo transfer. That used to be what everybody did back then. But then these days, it really shifted for several reasons. The first is the freezing technology really improved vastly over the years. And so that made it a lot easier to just freeze embryos to be able to use them later. You didn't have to be forced into a transfer when maybe those conditions weren't ideal. But the second thing is most patients these days really choose to do PGTA. That means genetic testing of the embryos. And the truth is, when you're testing, it takes time to get those results back. So you really can't do a fresh transfer in those circumstances because you just don't have your results back yet. And so that's why in the vast majority of cycles, this is freeze all. You pull the eggs out, you make your embryos, you freeze them, and then you're working on doing a frozen embryo transfer later on. But if you think about it, the fresh embryo transfer concept is very similar to natural. Either way, your body is making the majority of the hormones that you're going to need. And so when I think of it, I almost think of it like a circle. We're going in a circle.
I know. I don't even think about fresh transfers anymore.
Right. I know. Right. Absolutely.
Doesn't even cross my mind.
Yes. Yeah. But I thought it would be good for us to just kind of talk through maybe why somebody may be a good candidate or why somebody may not be a good candidate. So what are some of the factors that you think about when you're trying to decide if you should be offering this to your patient?
Mm-hmm. Yeah. So I think the really lovely thing about our patients at Peak Fertility is we really get to know them.
Yes. Yeah.
Right?
Yes.
And so I can almost predict in general which patients I already think, not just medically, but just knowing them, who I think a natural cycle will be. So here's the biggest medical considerations. First of all, if you don't get cycles on your own, you're not a candidate for a natural cycle, right? Mm-hmm. If you're a PCOS patient that does not ovulate on your own, you're really not a great candidate for a natural cycle. You can do maybe another subset of a modified natural cycle where we give you some medication and get you to grow a follicle, but you're not going to grow a follicle on your own. So you have to have regular cycles. That's absolutely very important. Also, you might be someone who you're not very good at growing a follicle and growing lining in response to that follicle, right? So you might be someone that kind of has lining issues in general, and you need higher doses of estrogen to make your lining grow, right? And we probably already know that about you if you already tend towards having some lining issues, right? We need to go about this a special way. Also not a good candidate. Interestingly, patients who are obese are also not great candidates for natural cycle transfers because there's some data to show you should actually use progesterone and oil still for those patients. And so with a modified or a natural cycle, we're typically not using progesterone and oil. We're using some supplemental vaginal progesterone, letting your body do most of the work itself. So I also don't really offer it for those patients. Here's the other kind of personal side of things, right? If you're someone that has a very busy lifestyle and really likes things to be planned out, you're not a good candidate for a natural cycle transfer. They're extremely unpredictable. We don't know exactly when it's going to fall. So that's not a great person, right? If I was going through it as a fertility doctor where I'm working all the time, I need to know what day my transfer is going to be on with some certainty, right? In advance. Not a great candidate. If you're someone who's going to be extremely disappointed in the moment, if your transfer cycle gets completely canceled, you're not a good candidate for a natural cycle transfer. I counsel my patients there's about a 10% risk with a natural cycle transfer that we're going to cancel you. Because if you ovulate before I'm ready for you to, or your lining isn't getting thick enough before you're ready to ovulate, anything's off with the timing, we're not going to put an embryo in when the circumstances are not perfect. You're going to get canceled.
Yeah.
And I have some patients that would crush them. That
Absolutely.
is not a good match for them. And we have a very candid conversation. They say, no, that makes me very nervous. I don't want to do that. You know?
Yeah.
So I can almost predict who is going to be kind of open to it and already, I think previously, right?
Yeah. Well, I think what is so challenging about the scheduling issue that you were bringing up too is, so when you do a program cycle, pretty much like you start your period, you come in for that baseline sonogram on the second or third day of your cycle, and we can already tell you, here's when you need to come in for your lining check and what day do you want to pick for your transfer, right?
Yeah.
You can even usually pick from some different options based on, of course, our availability too. And so you have so much notice as well. But with the natural cycle, that's what's so hard is as soon as you start your period, people are asking, when's my transfer going to be? And I'm like, you tell me, ask your ovaries, right?
Yeah.
And so it does require a lot of appointments because they do usually bring you in on the earlier side before you are even likely to ovulate because I don't want to miss it, right? So I kind of purposely bring you in too early. But then sometimes it comes down to day by day, right? So imagine you're coming in for your appointment and I'm like, okay, well, you're not ready yet. Can you come in tomorrow? And they're like, wait, I didn't have time to ask off of work, right? That's where you have more appointments, but also less time to even notify your work that you need to be gone. And that is really hard for our busy professionals. We see doctors, lawyers, and everything, and they already have stuff on their schedule that really prevents them from being able to do that too. So it is nice to have different options to be able to talk through and offer your patients as well. I will say maybe some other factors to consider is maybe your clinic. Can your clinic support a natural or modified natural cycle embryo transfer? And we are really lucky here. We do have the luxury where we're able to do transfers any time of year, but some clinics have to batch, right? Can you kind of explain why a clinic would batch and you know, just kind of explain too that it's okay, but then you just have different options.
Yeah. And there's definitely clinics out there that will group all of their IVF starts maybe once a month. And that way they'll also time all of their embryo transfer starts to all start at that same time. So that perhaps that's the only time of the month that they'll have an embryologist available to come in and work at their clinic. Maybe if you're somewhere more rural where there's not a lot of healthcare available, this is probably how an IVF clinic close to you is going to work. Maybe it's a clinic that has multiple satellites. This is one of the satellites where they come in and they batch every once in a while. Or smaller clinics, maybe that just have one doctor will do batching a lot. And so if they're not up and running the entire month, there might just be 1 week that they're offering embryo transfers. And if you're dependent on your cycle actually in the timing of your ovulating, you're probably not going to fall on that little week that they have available. And so you're going to do a program cycle.
Yeah, absolutely. And, you know, I think sometimes that can be frustrating on the patient side of things if you're at a clinic that batches, but oftentimes these clinics are working in underserved areas. And look, embryologists, it's very important you get good embryologists, right? But it costs a lot of money to hire full-time embryologists, right? And so, again, although we're lucky to have that, we definitely understand that sometimes there may be areas where that can't be supported and they're still trying to serve you and give you good fertility care, but sometimes you just don't have all those available options. Okay, I will say one of the best things about the natural cycle is no shots, right?
Yeah,
because you know how for our IVF, for kind of more of the egg retrieval part of it, we have this new device that a lot of our patients have been using with us. We call it needleless IVF, where we put a little pump on the abdomen and they can just squirt their medication through the pump. So you don't even need to do those fertility injections anymore, which is awesome. But imagine you've been doing that. And then we say, surprise, we've got some needles for you for the embryo transfer part. And this feels frustrating, right? Because my patient says, well, why can't I just use that pump again for the progesterone?
Yeah, so progesterone and oil, I think, is a little brutal. I definitely think it's the part of IVF. It's funny, like patients who did IVF 8-10 years ago, all they remember are the progesterone and oil injections. You know, it's really that part, I think, that sticks with you. The problem with progesterone is it has to be injected into the muscle. So it's a big needle and it's a deep shot and it makes you really sore.
Yes.
I describe it as it feels like you did a really hard glute workout, but you don't have any benefits of doing the glute workout.
Yes.
So for some patients, I mean, really, it's not tolerable to them. And it's the worst part of IVF. And luckily, when you do a natural transfer and you get 90% of the progesterone that you need from your own little follicle, you don't need PIO. You don't need the progesterone and oil injection. So it is a nice way to avoid. I will say, even some of my patients that do, like I said, modified or natural cycle transfers, I still think that they will benefit from progesterone and oil. So it depends on the patient.
Yeah. Well, you and I have both done progesterone before, progesterone injections. And I remember when I did them, I got what I call lumpy butt.
Yes.
Did you get lumpy butt?
Yeah, you have it for like a year later.
It takes a while to go away.
Yeah.
I thought it was so funny because one of the partners the other day told his wife, "Don't worry, honey, I like your lumpy butt." So I thought that was sweet. I'm like, okay, great.
It's there for a while.
But yeah, so I can definitely understand if you have the chance to avoid progesterone injections, why not? But I really do have other people who say I don't mind them, surprisingly.
Yeah.
But what I'm jealous of is in Europe, they have subcutaneous progesterone that you can give in the abdomen. And I'm like, why don't we have that yet? I thought we're the best in the world. Like US medical care, best in the world. We don't have that. So I heard that they're working on studies, but I'm super hopeful that maybe that could be a great option for us to add. You know?
Yeah. I just hope the levels are.
I know it's got to keep the levels up. Okay. Yeah. I'm glad you brought up levels because so some of my candidates for natural cycle FETs say, Dr. Reed, I don't trust nature. I've been working with nature for years and it's failed me.
Yeah.
And I need medical intervention and I don't trust my own hormones. And that's fair. So I get plenty of people who say, give me everything, give me all the hormones, give me the progesterone shots. And I have to admit to you, I also have trust issues with nature. I love nature. I usually like to go natural, but I have seen a kind of instances where the hormones are not as high as I want them to be. And so, and remember guys too, natural cycles are kind of something more we've just been doing in the last, 6 months to a year or so. And so I've been increasingly checking the hormones a lot more than I've needed to in a program cycle. When I checked in the program cycle, they're always so high. I'm like, okay, we're good. But in the natural cycles, sometimes they're great and sometimes they tank on you. And then I'm like, oh my gosh, hurry up. Now we have to add the progesterone shots, for example. And I always feel so bad because I'm like, well, gosh, this poor patient, she did the whole hard part of coming in for all these appointments just to avoid these shots. And now I have to add the shots,
Yeah, absolutely. I agree. I am pretty tedious with the levels.
Yeah.
And I also agree with our patients because I do a lot of natural cycle monitoring and I've seen patients' hormone levels just be really poor, especially in that luteal phase. And I think it can absolutely have an impact.
Yeah.
But I will say to the patient that ends up having to do progesterone and oil and did a natural cycle, there's also probably some other benefits to natural cycle transfers, right? So the way I explain this to my patients is when you ovulate, you have your little shell that's left behind called the corpus luteum. And we know for sure the corpus luteum is releasing progesterone, right? But it's also identifying it's releasing a ton of other chemicals that we haven't even yet categorized. We don't even know everything that's releasing, but it's probably a lot of good stuff,
right?
Yeah. There's probably something related there too to controlling your blood pressure during your pregnancy. So there's some data to show that you're less likely to get hypersensitive diseases of pregnancy if you do a modified natural cycle, or a natural cycle transfer. So I think there's other benefits, even if you did end up having to do a little bit more supplementing of your hormones.
Yeah. And I do find that so fascinating to think, gosh, there's things that the ovary makes that we just don't even fully understand at this point. And I do love that overall concept of what if nature does do it better than what modern medicine can do. So I do really like that concept too. But you know what? We didn't really talk about probably the most important thing, which works better, right? Yeah. No matter what somebody's preferences are, they want to know what gives me the highest chances of it working. And I feel like we do have some reassuring answers to that so far, right?
Absolutely. So these are equivalent outcomes. They really are. There's not a substantial difference, especially if you're going for your first embryo transfer, if you're going to opt to do a natural cycle transfer or a program cycle transfer. There really is not a big difference. However, there are some crossover studies that we looked at back when I was in fellowship. I have some issues with crossover studies, but they looked at patients who failed their first transfer doing a program cycle embryo transfer. And then they crossed them over and tried a natural cycle, or they kept them in the program cycle track. And those women that crossed over and tried a natural cycle next had slightly higher success rates in that second embryo transfer. So I actually kind of agree with some of these other doctors that are arguing out there.
Yeah.
I kind of offer my patients the standard of care first, right? The fastest, most effective, tried and true. Let's do a program cycle first for most patients, unless there's really a reason not to. And then if we don't have success, then we can talk about doing natural cycle transfer, right? I think that it's an open conversation if they want to do it right off the bat, but I don't think there's any reason that you need to feel like you're doing something wrong by not doing a natural cycle first.
Yeah, I'm glad you brought this up, because I'm going to add another layer of complexity to it, which is sometimes we'll try an embryo transfer cycle and it doesn't work. And then for whatever reason, we may suspect they have endometriosis or adenomyosis or something like that. And we say, you know what, before we try again, let's do some hormone suppression on you so that we can optimize your chances for success. This is all debatable too, right? But this is a pretty common treatment we do. And imagine if you are suppressing the ovaries for 2 months, your hormones are going to be essentially zero. Your endometriosis and adenomyosis should shrink. But now imagine trying to do a natural cycle after that. That's hard to get the ovaries to wake back up, right?
Yes.
I mean, I wouldn't say it's impossible. I have done it. If I have a patient who really wants to do it, I will do it. But I'm like, it's probably going to be expensive, right? Because really, oftentimes you're having to give fertility meds again, including like Follistim or Gonal-f or something like that, to wake the ovaries back up.
Yeah. And I just don't think there's enough data to support it.
Yeah.
You know, it's like you're operating in a weird space.
Yeah.
You know?
Yeah. And so, so I think that's an instance where I often lean towards programmed over natural.
Yeah.
Now, let's say we did our 2 months of hormone suppression, we tried a programmed, it didn't work. Well, and then we're going to try again. Then you can usually do a natural because the suppression is worn off enough that your ovaries are going to be able to wake up a little bit more easily at that point. But I think that goes back to the whole point of like everybody's kind of case is just a little bit different, and you never want to be just black and white in your recommendations and your conversations. It's things to really kind of talk through together. I also wanted to talk through a couple of things when I've looked at the studies that I've noticed. First, I noticed that often the studies that have been coming out recently and hitting social media, it's always a headline, right? And I don't know that people are actually reading the study, but the headline usually will say, program cycle and natural cycle are equal, or maybe even natural cycle is better than programmed or something. But when I go read the study, in almost all the circumstances, they're calling a program cycle estrogen followed by progesterone, but it's usually either vaginal or oral progesterone, because many of these studies have taken place overseas where that is their standard of care. But you and I both know that is inferior to progesterone in oil. We have very good data to show vaginal progesterone alone is not enough in a program cycle, and oral progesterone is not enough in a cycle. So I'm honestly kind of even stumped why they do that overseas, because here in the US, we know if you're going to do a program cycle, you have to have progesterone in oil. And so knowing that that is what gives you the highest live birth rate, I have yet to see a head-to-head of program cycle with progesterone and oil to natural cycle. That's what we really need to see, a prospective randomized control trial comparing those two. And once that's done, if there's one better than the other, I think we're all going to change to whatever it is, right?
Yeah, absolutely. And when we would review a lot of these, what I would notice is there's so much heterogeneity in what they're calling a natural cycle. Like I said, it was actually very hard for me to find papers that do natural cycles like I do.
Yeah.
So
right. Yeah. And then the other point that I was going to bring up is most of the studies that I looked at where they compare program to natural cycle are retrospective studies. And you have to understand when you're doing a retrospective study, that means you're looking backwards to see, okay, well, these people did natural and these people do programs, so let's compare. But you have to understand the biggest confounder there is that people who did programmed were probably people who weren't candidates for a natural cycle. And so what are people like that? Well, maybe like you mentioned, the obese patients or the patients with polycystic ovary syndrome. And we know these are patients that are already at higher risk of high blood pressure and preeclampsia and everything too. So whenever I've seen some of those, oh, well, natural cycle has lower rates of this. And I'm like, but does it really? And I'm curious. I do want to know, because it could just be that you're studying two very different populations without really accounting for that as well.
Absolutely.
Yeah. So then the other thought I had, because of my trust issues, right, is what if we kind of combine the two, right? I was thinking, and of course they're not going to have this study yet either. What if you could get the benefit of a natural cycle where you let your follicle grow, you have a corpus luteum making all those important hormones and substances, but what if we also added progesterone and oil, right? Because I do think that can be really important for people. Of course, it's still a shot, which I don't want for patients, but I do think you could use a lower dose because instead of replacing, you're just supplementing, right? So I think you could probably get away with a much lower volume, less lumps. And could maybe even spread them out too, right?
Yeah, absolutely. And I do think it's such a personal preference. I have patients that hate the vaginal progesterone.
Oh, yes.
I think I'm one of those patients too. It's just so messy and sometimes it can be itchy. And in some ways, the progesterone oil is cleaner.
Yeah,
like you do feel like a little bit more tidy.
Yes, tidy. I love that word.
Just in my own experience. So I can understand, like, some of my patients are like, no, I'll definitely do the PIO. I do not want to do vaginal. I'm like, okay.
Yeah. Perfect. Well, I guess what I would say is, at the end of the day, it really amazes me. Science and technology have advanced so much, but we're not there yet. It still always stands out to me how I was showing a patient. I say, okay, my current per embryo transfer rate is 76%. And I kind of say that proudly. And they were like, that's a C. And I'm like, what? You made a C on your test. And I'm like, oh, that's a good point. Because here I'm comparing it to like many years ago when pregnancy rates were probably like 20% or something. And here, we need to be making A+ on our test, right? I need to be making 100%. And I think you and I are always in pursuit of perfection, right? So how can we make it better, not only in terms of success rates, but lowering pregnancy complications and just making the journey as easy as possible for our patients as well. So we have lots of work to do.
Yeah, absolutely.
Perfect. Okay, we'll go ahead and wrap it up for the week, and we hope you guys have a great week. If you would be so kind, we would greatly appreciate if you would leave us a review on our podcast page, our YouTube page, and or our Peak Fertility Practice page. Bye.
Bye.